Hello and welcome to this video by MedGuide. In this video I'm going to be talking about the essential terminology that we've learnt this year to navigate our way around the body and why it's important in relating what we see in the hospital to what we learn in lectures, and it's relevant to us as future doctors. So the first thing I want to talk about is the anatomical position, what it is, why it's important. So the reason we have the anatomical position is it standardises body structures and body parts across anatomy. So everyone knows in the anatomical position which structures are in relation, where they are in relation to other structures. For example, if I'm jumping up, my thigh and my leg are going to be in a different position to if I'm crouching down. If my hands are above my head, they're going to be in a different position to if I'm reaching for something on the ground. So therefore, we have the anatomical position. So what is it? It's feet slightly apart, and I'm standing upright, I'm at rest. My arms are rotated outwards, my palms are facing forwards, and my thumbs are pointing away from the body. And your thumb lies on a different plane to your other digits, which is important in block 4 when you're learning about the different names for the different movements. The next thing I want to talk about is anatomical planes. So the first one is the coronal plane. So the coronal plane, so what is a plane? A plane is just a horizontal or a vertical division through the body, and it's essentially how we divide up the body along those lines. So coronal is a vertical division. So if we turn Shelley round, it's going to be running along the vertical axis of her, and it's a division through her like this. So this is a mid-coronal division, and it doesn't have to be in the middle, it could be further back, but it just slices along the body like that. It divides the body into, so on me we have a division here, it divides into an anterior part and a posterior part. The next plane that's important in anatomy is a sagittal plane. So a sagittal plane is, again, it's a vertical division along the vertical axis, but this time it's twisted 90 degrees to what we saw with a coronal plane. So it looks, this model is a mid-sagittal model. So we've divided the body into a left side and a right side by vertically dividing through the middle of the body like that. Again, it doesn't have to be in the middle. It can be to one side or the other, but this division, which is equally on the left side and the right side, that's called a median sagittal plane. So if we bring those two together, later on this year in block 5, when you're learning about reproductive and child health, you're going to learn about the skull in the infant and the sutures. So when we're born, our skull isn't fused together, it's actually in separate parts, which you'll learn the names for those later on. And they later in life join together to make these sutures here. So if we think about this one going along the middle of the body here, that's a sagittal suture. This one here going across, that's a coronal suture. The final plane, which I want to talk about, is a transverse plane. So that is through the body. This one's not vertical, this is a horizontal section. So we're cutting through the body horizontally, and then we're looking across there. So, for example, in CT imaging and in MRI imaging, a lot of the time, you're looking at a transverse plane. So, first of all, what is superior? So superior means above. So if I just move Shelley out of the way, this is an MRI. We see the vertebral column and its bodies, the spinal cord, and then further back here, these are the spinous processes. So you're going to learn about that anatomy in block 3 when you do neurology. There's a lesion here. So a lesion just means damage, so just some damage to the spinal cord. We can say this part of the spinal cord is superior or above the lesion. This part of the spinal cord is inferior or below the lesion. This is an X-ray. and it's a posterior dislocation of the hip. So this is something that, as an A&E doctor, you'll see quite regularly. And the reason being, a typical mechanism for this happening is in a car crash. So this is the hip joint. We've got our femur here, we've got our 3 bones which make up our pelvis, and these are ligaments. So a ligament attaches bone to bone, a tendon attaches muscle to bone. So here, bone to bone, ligament. The reason that we see a lot of posterior hip dislocations is there's 2 ligaments here. This is one, but it's bifurcated, which means split into 2. So 2 ligaments at the front, only 1 ligament posteriorly. So that's why you see more posterior hip dislocations. Additionally, a common mechanism of action for this happening is in a car. So if you imagine me sitting in a car, like so, and I'm driving along with my hip like that, and then I suddenly hit the car in front of me, there's a massive deceleration of the car, and my hip is going to be flexed up like that. And what do you notice with the ligaments between when I'm standing upright and when I'm sitting down? The ligaments become much more lax. So when you're sitting in a car, like so, and your legs up like that, you slow down, you keep moving forward, and your knee hits the dashboard, the force gets transmitted through the femur, and the head of your femur can actually pop out the back, like so, and that's a posterior hip dislocation. So on the slide here, we see an individual who is externally rotating their arms. So on the right hand side, okay, so on the slide here, we see an individual who is externally and internally rotating their arms. On your right, so here, you see this individual is externally or laterally rotating. So lateral means relative to that median line, the middle line, is going towards the side of the body, so away from the midline. And on the other side here, this individual is internally rotating their arm, and that's moving towards the midline. So lateral, away from the midline, medial rotation towards the midline. And it's really important in practice because in neurology, so in block 3, you're going to learn how to do a neurological examination. And one of the tests you do, so we test their power, amongst other things, but to test power, you get them to push in and out against your power, and that tests that they've got normal power in those muscles. So here we have some transverse sections of the spinal cord and the brainstem, and transverse, again, horizontal division across the body. The bottom 2 are the spinal cord, and then we have some divisions which are the brainstem. The brainstem you'll learn about in block 3. All it is a connection between the spine and the brain. Importantly, what we need to learn now is the terminology. So this is an axon which is running ipsilaterally, just means on the same side, and then it crosses over, and the term they'll use is decussate, just means crossing over. So it decussates across onto the other side, and now it's running contralaterally, so on the opposite side to where it was before, ipsilateral and contralateral. There's 3 layers to skin. Superficially, we have the epidermis, below that is the dermis, and then below that again, so deep to the other layers, is the subcutaneous fat. And that's really important when you're looking at burns and how deep a burn is. You're going to look at the different layers and how deep that burn goes. Also malignancy, if you're looking at a skin lesion, a lesion just means an abnormality. How deep that has gone, you're going to measure it by how deep, what layer of skin it's got down to. Okay, so here we have a view of a femur. And the terminology I want to learn now is proximal and distal. So this is the head of the femur up here, and we have the neck of the femur here, and the shaft, and these are the femoral condyles. When you're thinking about proximal and distal, it's to a point of origin. So if we say the mid shaft here is where we're starting from, proximal to that, so up here you have the neck and the head. distal to the shaft is the femoral condyles down here. So proximal and distal. Again on Shelley, another example. We have the elbow here. We have the elbow as the point of the origin. So we're saying, okay, what's proximal to that? It's the humerus. What's distal to that? It's our radius and our ulna. Now I'm going to look at some different modalities of imaging. So you'll come across a few imaging methods this year. This is an X-ray, and we see we've had a fracture across the humerus, and it's in an anterior-posterior direction. The harder, more dense stuff will appear white, and the softest, the less dense stuff like air or skin doesn't look quite as white as bone because it's not as dense as bone, and then the air around the person is even less dense than the soft skin, so that appears black. This is a CT scan. So an important thing to remember about CT scans is you're standing at the, imagine the patient is on a bed and you're standing at the bottom of the bed with their feet pointing towards you. You're looking at the CT scan like you're at the bottom of the bed using their feet as binoculars to look up through the body. So their feet are in front of me, I'm looking through and up the body, and it's then a section across the body at that point. So for example here, if this individual is on the bed like that, we'll relate it to this CT scan. So I'm at the bottom of the bed, the patient's there, and what can I see? I can see here the outline of the liver. This is the spine. So we'll recap a few terms. So anterior and posterior. So the patient is laying on the bed, anterior, posterior. This is lateral here. So these white things here are the ribs. So they're lateral to the midline. We can also see the stomach here, and we can see the fluid line here. This is a fluid line, so everything in the stomach has settled down to that point and it's formed this line here. We also see the spleen, and this is the top of the left kidney, because remember, we're standing at the bottom of the bed looking up at the patient. Okay. So this is an MRI, and as you can see, it's more detailed. So so why would we use a CT instead of an MRI? A CT is much cheaper and it's quicker. An MRI, obviously, as we can see here, gives a much better detail of fine tissue structures, but it is more expensive and it does take more time. So there are certain indications of when we use it and when we wouldn't use it. And again, this would be anterior, this would be posterior. We can see the spinal cord here is inferior to the cortex of the brain up here, which is superior to it. Okay, so how can we relate those together? So you're on the ward, you're a first year medical student, and your consultant has decided to take you to A&E. And when you're there, a patient comes in and they've been involved in a road traffic collision. So a young motorcyclist has been thrown off their bike. They look very unwell, there's obvious fractures. We need to see if there's any other fractures throughout the body, and we're also worried about bleeding. So we're going to use some different imaging. So first of all, we're going to get them to go for an X-ray to look for fractures. So this is our pelvis up here. This is the outline of the left thigh, and running through it, the longest bone in the body, the femur, we see an oblique fracture across the mid-shaft of the femur. So the patient's had an X-ray and we've identified the fracture to the long bone. Now what our next worry is there any bleeding, particularly in the brain, but also the abdomen. Why we're worried about the brain is the brain is a closed space, so the cranium or the skull is hard and it's fixed, and if there's swelling in the brain, it can't make the skull bigger, it will just compress, and it will have to compress inwards. And what you're worried about then is necrosis to the brain tissue. So if the pressures inside are so great that the brain's not getting oxygen, it can die, and it can also push stuff down and out of the skull, which again is incredibly dangerous for the patient. So we've got two options. We've got CT or MRI. CT, as we said before, it's much cheaper and it's quicker. MRI is more expensive, but it does give fine detail of tissue structures. So for our motorcyclist that's come in, we've given them a CT because it's an emergency and we need to see quickly, is there any bleeding in the brain? We can also see any fractures, and then perhaps a few days later, we're looking for any damage that's been done. So we then send them for an MRI of their head, and the MRI allows us to see in much greater detail any damage to the fine structures of the brain. In our motorcyclist patient, let's say that the CT did show that indeed there was a bleed on the brain. We've got an option, which is to speak with the neurosurgery team, and one of the things they'll do is they'll use a drill and they'll drill a hole in the patient's skull, and that can then relieve some of the pressure in the skull, taking that pressure off the brain, and that's called a burr hole. Again, something like that you may see particularly in second and third year when you're spending more time in hospital. Okay, so that concludes this little video on just some terminology. I hope it was useful.